Okay, we're starting here at the conference for the Endoscopy skull base with Salman Sharif, the head of the conference. He's at the podium now.
Today's morning is opening with a very sad news. Our very dear colleague, Dr. Khurram, passed away yesterday due to MI. A very good fellow, jolly person, always stood against unfair and always helpful to all poor and the younger colleagues in their academics and education. And we are really going to miss his jolly life and his jokes. Really a great loss. May his soul rest in peace. Amen.
Okay, I think we're going to start. The plan is that the endoscopy talks will finish first, and then we have Kim do spine talks while we're preparing the case. And then once we're on, then we're going to have Led have a mic that he's going to take around and make sure that he makes you revise a bit of vascular stuff that we have learned during these last few days. And Kim is going to make you revise what he will teach as well at the end. So that will make sure, and then there'll be interactive from here into theater. And that may be the best thing for everybody to learn out of what we're going to do. Okay, I'm not sure if I don't think I'm doing surgical approaches. I'm not going to go into that. This is actually Karakoram range, and this is one of the mountain range that the Pakistan Army had brought about 12 top skiers in the world, and they went onto these virgin mountains and skied with a pre-planned computer hologram, so they knew exactly where was what, and they were able to ski in those areas which nobody had skied before. So it's an unbelievable video. It's actually available on the net. I'm not going to go into those details. We're going to learn a bit about ventricular anatomy. And I just want this to be more interactive than usual so that we can all remember. It's actually, everything is there. So if you remember, you've got these lateral ventricles, you've got the occipital horn, and you've got the foramen of Monroe coming down into the third. And what is this white thing in the middle? Good. And then, you've got anterior commissure, posterior commissure there, and you've got these mammillary bodies at them in front, and then we can see the aqueduct coming into the fourth, and the Lushka and Majendi in the middle. So again, the same thing, and this dinosaur that we see all the time who's trying to eat up like Pac-Man. And we have the same issue that, how things are being formed. And you just need to have this 3D image in your mind anytime you want to be doing endoscopy in brain. If you want to be, like, is it possible? थोड़ा छोटा कर दो. Thank you. Sorry. That's okay. That's fine. So we just need to remember that if you're looking at the lateral ventricle, we know that this thalamus is lying. Where is the thalamus in the lateral ventricle? Any takers? Okay. And septum pellucidum in the middle, as we can see. What is this structure that goes all the way around and goes into the temporal horn then? Yeah. And it has, what is that? Yeah, so you have mammillary bodies, and you've got the two columns in front, go all the way around, and then go around and end up as hippocampus. So it's it goes all the way around, and then you've got the crest of the fornix and the body of the fornix, and that goes underneath. So we know all this, but in order to imagine 3D, I've just shown you coronal, sagittal, and axial pictures for us to know exactly what's happening. So these columns, as you can see, they curve round like that, go around, and this is go around what? Yeah, so they just go around the foramen. So it's basic anatomy that we already know, but we need to keep in mind. And you've got these fimbrias that go all the way around and go on to the hippocampus. So when you're doing temporal lobectomy and when we're trying to do a mesial hippocampectomy, all these structures are important for us. So same thing if we see in a different way. So you've got these two anterior horns. What is this vessel? So carotid. Carotid is going into showing the choroidal artery. So that's important. We know the anterior choroidal artery arises from which part of the carotid? Well, I'm sorry, didn't get you. Can we give the mic so that, because that's being recorded and then we wouldn't know. Okay, fair enough. But I'm saying just say everything in the mic. Maybe you can keep the mic and then you can pass to people or whoever require it. And then obviously we can see that basically choroid plexus go all the way along into the temporal horn. And all this is important that you have got these vessels going in there. So in case you want to go in this area, you need to be sure you know what exactly you're doing in this area. Again, we see the dinosaur sitting up. So now this time it's a caudate nucleus that we are looking at. So we have got the head of the caudate nucleus, and you've got the body which comes around, and then that's the tail, and all the way it ends up as a amygdala. Okay, so caudate nucleus comes around, takes a U curve. So you've got two bulbs on each side, the big bulb on this side, and a small bulb which ends up as amygdala. The two column of the fornix, the mammillary body, obviously all this we have just revised, hippocampus that goes all the way along. You've got the two forceps here, the forceps minor in the front and major at the back, and you can see the connections that they're there. So all these are important for us, and you can see the same thing again, that you've got the body of the corpus callosum up there, and you've got the two ventricles, and again, what we're seeing is the caudate nucleus just going around with the genu. What is this genu of? Corpus callosum, and obviously comes around. So I think, you just need to remember this 3D image in your mind, and I think there are some very nice videos on internet that you can download and really see which structure goes where. The venous drainage, obviously all that is very important for us. There are a couple of veins which are very important inside in the ventricle. With these veins, we would generally not see it per se, but if you see this foramen of Monroe coming out, and you can see that there are two main veins that are coming from front and joining. Do you know which two veins are in the anterior part of the lateral ventricle? Frontal horn? Two veins. No, thalamus striate is not there. Caudate. Okay. Yes. Where is thalamus striate? It's behind. So it's actually in the body itself, because it's dividing the striatum from thalamus. So it's running in that sulcus. Okay. Anyway, so different approaches that we can take if you want to be doing different approaches when you're doing craniotomy. So you've got the middle frontal gyrus incision. It's a safe area to get in. Superior parietal incision. It's again a safe area, lateral temporoparietal incision. And we have got the occipital, and then transtemporal horn incision going through the occipitotemporal gyrus. So you can have these various incisions in order to make sure that you are able to approach different structures. So let's revise what we just learned. Okay, so when we look at frontal horn endoscopically, you can see what is this foramen? Monroe. So what vein would be on the septum? Okay, and from caudate, which vein is going to come down and join it? Okay, so and then what is this white structure, white matter structure? It is white, you see it is white. So the white matter structure is corpus callosum, so it comes round. What is this structure that goes around here? We have seen the column of the fornix. So this is very simple, so we can remember this. So if you look at this, you have got this caudate nucleus on side, you have got the septum, you have the genu, you have the rostrum in the middle. So anterior, all this is anterior to the foramen Monroe. You've got the anterior to the fornix. And roof is formed by the corpus callosum. Obviously, anteriorly is again corpus callosum. Lateral wall, we said there's a head of caudate nucleus. So we remember that bulb that we had seen. And medially is septum pellucidum, and floor is formed by the rostrum of the corpus callosum. And we can see all this if we see these two, and we will be able to remember. Okay, and the structures in it, there is no choroid plexus in this, and that's why people prefer to put sometimes shunt in the frontal horn if they continue to get blocked or whatever. And there's the important vein is anterior septal vein, and you've got caudate vein, anterior caudate vein laterally. I don't know if let me show this anyway. This is one of the third ventriculostomy. So which side are we on? How do we know? Wait. Which side we were on and why? How do we know that it's left side? What is that? So if the septum, this is septal vein we call it, and if this is septum and this is thalamostriate coming down, so what side are we on? Right side. So I think it's important because, you know, when you're doing freehand, you can get lost. So it's important for us. So you go in and you can see nice, juicy. Which structure are we making hole in? Which structure are we making hole in? Are we? Are we making hole in tuber cinereum? What is this made up of? What's this tissue made of? What do we call this? It's just floor, but what is the floor? Okay, it's extension of, yeah, so the lamina terminalis come down and there's extension of lamina terminalis, okay? So then you need to make sure that you're able to see that the opening is below, going all the way below, there's no problem. And these, if you plan the image guided, then it's much easier. Let's come to the body. Body comprises of limits. The posterior edge is from the foramen Monroe to the splenium. Roof is formed by the body of the corpus callosum. Lateral wall is with the body of the caudate. And then we have got the floor, which is formed by thalamus. So that's the floor formed by thalamus. And we have got the sulcus between the caudate and the thalamus, and there's a choroid fissure. And the structures are thalamostriate, thalamocaudate, and posterior caudate veins. Medially is the medial posterior septal vein. So anteriorly we saw there was anterior septal vein. Here in the middle, it's posterior septal vein. And we come to the atrium. Again, the limits are the posterior edge of the thalamus. So we're coming all the way to the back. So it's the pulmonary eminence. So we see a eminence where the bulb of the corpus callosum comes. So we've got the roof, which is formed by the splenium and the tapetum. And then, so tapetum is on this side. You can see forceps major goes along all the way at the back. And then medial wall, you've got the two horizontal prominence. One is calcar avis, which overlies the calcarine sulcus and the forceps major. So this is calcar avis. And then floor is formed by the collateral trigon, which is shown here. So you've got these two eminences you need to remember. This is a triangular area. And there's a bulge from the posterior end of the collateral sulcus over here. So this is the endoscopic anatomy that we're trying to learn from inside. So we know exactly if you're putting an endoscope, what happens. What are the structures in it? There's lateral and medial atrial veins, anterior choroidal artery, lateral posterior choroidal artery, and glomus of choroid. What happens if you take anterior choroidal artery? Where does it supply? Can we give a mic to somebody? No, you're going to tell us. Man, anterior choroidal artery, you put a clip on it.
Memory is lost.
Ask Vlad. Let's examine Vlad.
Well, Fred,
Total hemiplegia.
Yeah. I'm sure people have seen that. It's many times it happens because of spasm as well, but sometimes it's your clip which is inappropriate.
Fred,
So we have to be careful there.
Are you in Minnesota or you're in
The
Washington?
limits, I'm not sure why the diagram is not showing. Limits are tapetum, lateral wall is tapetum as well, forceps major, calcar avis again, collateral trigon again, structure is no choroid, lateral, medial, lateral vein. So it's exactly the same. Temporal horn. I think temporal horn, if so we are coming all the way back, if you remember hippocampus lying medially, and you've got the thalamus, the caudate, and the fimbria, and you've got the tapetum on the lateral wall. So you've got the lateral wall, and the tail of the caudate nucleus comes all the way to the back. Medial wall is choroidal fissure, which is between thalamus and fimbria. So between fimbria and thalamus is the choroidal fissure. Why is choroidal fissure important? Anybody tell me? Clinically, why is choroidal fissure important? Name? Vlad, can you help us with clinical anatomy here? Why is the choroidal fissure important?
If you are performing hippocampectomy, you follow the fissure.
Yeah, so you come to the fissure and you follow it. If you don't follow it, what's going to happen, Vlad? What's going to happen if you don't follow it and go straight in?
You end up in a peduncle.
Yeah, so if you go into the peduncle, that's history for the patient. So poor patient won't know what's going to happen. Anyway, the floor is collateral eminence and hippocampus. We have talked about it. Structures: transverse hippocampal veins, inferior ventricular vein, amygdaloid vein, and anterior choroidal artery. So that comes all the way back. So when you're doing mesial temporal sclerosis, or when you're operating on some tumors in this area, then obviously you need to know this anatomy, and it's very, very important. For endoscopic anatomy, I'm not sure if it's very helpful at the moment. I cannot see into the temporal horn itself, it's just with rigid scope very clearly. Can you, Pepe? Temporal horn?
Doing the correct section.
You go there, you follow it.
Yes, with very large ventricle, you can follow the
Okay.
almost until the half. The tip you cannot see.
And you're probably better off, because otherwise you'll damage the choroidal artery anyway if you follow that. So let's revise. Can somebody tell me all the walls? Who's going to volunteer for, let's revise with frontal? Yes, maybe you can give it to Usman at the back and he can pass, so we can take one at a time. So we are at A, frontal horn. So what's the roof, what's the floor, what's the lateral wall? Come on, it's there.
The medial wall is the septum.
Okay. Lateral?
Lateral caudate, head of caudate.
Yeah.
And roof is, and floor is rostrum.
So B, who's going to take B? So give it to somebody up there, yeah? So B.
So B is body area.
Yeah.
Having roofed by corpus callosum.
Yeah.
And laterally, again, caudate nucleus.
What do you say
In
about
the
that?
floor,
Big thing in the middle, on the lateral ventricle in the body.
thalamus
Yes.
is there.
Thalamus. Yeah.
And laterally, we have
Again.
caudate nucleus.
Yeah. Okay.
Yes.
All right, good. See, move on. Yes, next.
So C is the occipital horn.
Yep.
The roof is formed by the corpus callosum.
Yep.
And the lateral wall by the tapetum midbrain part.
Okay. And then two eminence. Okay, good. And then last. Yep. No, if somebody in the mic, please. Take the mic, tell us.
So temporal horn is formed by medially by tapetum, and roof
yeah, okay.
And roof is caudate nucleus and thalamus, and lateral wall is by hippocampus.
Okay, and the choroidal fissure was where? We just revised it here.
Just below the hippocampus.
Really? No. Where was the choroidal fissure? Between what and what? Fimbria and hippocampus. Fimbria and, yeah, okay. Right, so let's, I think I'm not going to confuse you further, but I think if you just basically have an idea how vessels are going, so carotid comes in, and you've got MCA branches going all the way and obviously into the sylvian fissure, and then you have got the PCA coming on this side and going all the way up. You have the anterior choroidal artery, which takes a loop, goes up and curves around and ends up in the temporal horn. Okay. So arterial vasculature, the lateral ventricle, anterior choroidal artery is very important. You need to remember this. It has two segments, cisternal and plexal. It arises from terminal segment of ICA closer to the origin of PCOM, then the carotid bifurcation. It frequently anastomoses the branches of other choroidal arteries and sends branches to various structures, optic tracts, cerebral peduncle, globus pallidus, origin of optic radiation. So if you take this, you're going to cause serious problems to all these structures. Posterior choroidal artery, on the other hand, it arises from the posterior cerebral artery, P1 segment. Anastomosis is often found between medial posterior choroidal artery and lateral posterior choroidal artery through the interventricular foramen. It gives feeding vessels to choroidal plexus of the lateral ventricle, except anterior anastomosis at the level of interventricular foramen. It's the medial posterior choroidal artery. Okay, lateral posterior choroidal artery, number per hemisphere ranges from 1 to 9, average is 4, arises from P2 or P3 segment of PCA, runs laterally to the PCA and enters the choroidal fissure, and area of distribution is cerebral peduncle, fornix, pulmonar, and caudate nucleus. So that, basically you just have a fair idea what the supply is, where you're going to go from. Venous structures. Okay, so, I think what we could do is if you follow this from the other end, it may be easier. You've got internal cerebral vein joining together and forming what? Yes, who has the mic? So what have we got? What structure is this?
Great vein.
Yeah, okay. And if we come from front, if we think we are coming from front, so you've got this anterior septal vein, and then we have the caudate joining together. And then you've got the thalamostriate vein, which runs laterally. So, and that's and the thalamocaudate vein as well. So, so these two are running in the lateral ventricle in the body all the way back. Veins, again, choroidal veins are bulky and tortuous, easily seen, runs over the plexus. They provide valuable landmarks in deciding the surgeon regarding the foramen Monroe and choroidal fissure during the operation on ventricles. So we talked about it, that why septal vein is important for us is because then we know we're in the right ventricle, why the choroidal fissure is important for us. So all this is important. So superior choroidal vein is very bulky. It drains the glomus and runs ventrally towards the ventricle body to enclose to interventricular foramen in thalamostriate or directly into the intercerebral vein. Inferior choroidal, on the other hand, ends in inferior ventricular vein and also in the basal vein at the same place. And the medial choroidal vein courses from the plexus of the ventricular body directly into the internal cerebral vein. So veins, they generally lie on the medial wall. Anterior septal vein, the most constant, drains into the venous confluent of the interventricular foramen. And then obviously all these veins are important for us, and we just need to have an idea who, where. Thalamostriate, the most constant, runs in the thalamocaudate sulcus and forms the venous angle with the ICV through the interventricular foramen. So what is this? Why is this venous angle important? Anybody knows? I think Vlad is going to offer his services again here. Okay, so come on, man, you have to answer. Vlad, get them to talk, please.
Thalamostriate vein and internal cerebral vein, then turning upwards to the vein of Gallen.
Yeah, so it's so important. Otherwise, we can cause serious problems. And many times when we're operating on the temporal lobe, all these things, because these angles are important, that we're going to take anything which is behind and not take anything which is in front. This is a video that I downloaded from YouTube, which gives revise what we have just said and done. And I'm just going to fast forward here and there if I can. So it's a 30-degree scope that we have, and looking exactly like we had seen before. So we know that's foramen. This white thing is corpus callosum. This thing is fornix. What is this? This is choroid plexus. So this vein, big vein, yeah, good. And this vein? Okay. And what is this here? No. This is septum pellucidum, but what's there? Below septum pellucidum. This. Yeah, so fornix, okay? And this is already, there are some opening in the septum pellucidum here. Okay. So what veins are we going to see here in the body? Two veins. In the body, two veins? What is that? We just said thalamus right and thalamocaudate. Yes? So that's whole thalamus lying in the middle, bulging at us. And what is there laterally? In the groove that we have the there's the sulcus on which the veins runs, thalamus right. So what's lateral to that? Yeah, so that big bulky dinosaur that we saw, the green dinosaur, that's lying laterally, so it's caudate, that's lateral. And the caudate vein that joins there. So what happens when you go in there? What are you expecting to see? Okay, so this area is what? Okay, and it's, what about this thing here? Okay, so this is good. This is anterior commissure that we're able to see here underneath. Yep, okay. And we say the chiasm goes here. So recess above that is supraoptic. And you have the two mammillary bodies here. And this is what I was asking, was infundibular recess. And underneath is dorsum sella. Yep. So you've got these mammillary bodies, and where are you going to make the hole? Here, 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 here. A, B, C, D.
B.
Yeah. So it's not fixed. Obviously, you need to be careful. You need to be safe. That's the most, you cannot be very close to mammillary body. Cannot be very close to the vertebral if at all possible. Some people make opening with the blunt opener. Some people make opening with a crocodile. Some people make opening just with coagulation. I usually use bipolar. So, you can use whatever you need to be comfortable with it. And this is the recess. So here we have a crocodile, I think. Yeah. It's really thin, so you should be able to see the vessel underneath, but I think it's a little opaque for us at the moment. This is not my video, by the way. I wouldn't spend this much time in operating room and with endoscope. For ETV, it should not take more than 5-7 minutes. Unless you're biopsying or doing something else. So you need to look underneath and make sure there is communication. So what do we see underneath then? So he's trying to see if there is communication there. So, I think there's some opening there. Okay, so they just wanted to see the basilar on that side. And let me see, is there anything else? And you've got the perforators. Okay, I think we're going to move on. and how to decide which approach to take. I'm not going to talk about approaches today, but depends on location, tumor extent, how much of hydrocephalus there is, how big the ventricles, right is bigger, left is bigger, what deficits patients have, what are your goals of surgery, depending on the pathology that you think, the shortest possible route to that problem, straight route to the problem, the vasculature, and surgeon's experience. So depending on all these approaches, you can decide various approaches, and I'm not going to go into that. We're going to go on to our next talk from here. So you could have occipital, transcallosal, transcortical, transcallosal, anterior transcallosal. You've got anterior transcortical. You've got the anterior frontal, posterior frontal, temporal, depending on which area of the ventricle you want to be approaching. And you can do the same with endoscope as well. So thank you very much. Any questions? Okay. Pepe, you want to go second? Yeah, that would be great. Oh, you have a max. So this
is stepping to the stage.
Thank you, Salman, for the wonderful talk.
Salman Sharif
for
stepping down.
Adaptation of normal anatomy to endoscopic anatomy. Endoscopic anatomy is always so much different from real anatomy.
A little blackout here on the screen. We'll just show the audience, give an audience shot. Boy, does it get any more exciting than this? In these days of the internet, live internet, 2 video platforms. I have Facebook.
So let's start now with the indication to the ETV. And I always remember the fact that in next year, in November, we will have the 9th World Congress on Endoscopy in Orlando, Florida, and you are all kindly invited to that. So let's go through the indication to endoscopic third ventriculostomy. Endoscopic surgery is a real alternative to the implantation of the shunt in many cases of hydrocephalus, but certainly we have to remember that hydrocephalus is the result of a wide variety of pathological conditions with different pathophysiological mechanism, and that third ventriculostomy is not indicated in all forms of hydrocephalus. So we have to select carefully our patient where to perform an ETV. Indications to ETV, we will retain mainly obstructive form of hydrocephalus, and we will see how the ETV performs in this different indication. Aqueductal stenosis is the main indication, but we also can perform ETV in post-hemorrhagic hydrocephalus in some cases, posterior fossa tumors, pineal tumors. These all are obstructive form where the obstruction is due to the tumor. Myelomeningocele is a multifactorial hydrocephalus, but there is a very strong obstructive form at the level of the posterior fossa. Some patient presented with shunt malfunction, and some other cases with Dandy-Walker and other form of obstructive tetraventricular hydrocephalus. Let's start with the aqueductal stenosis. We all know that we can do a positive and certain diagnosis of aqueductal stenosis with sagittal cuts of MRI that clearly shows, even in T1, but most frequently and better in T2 and in drive sequences, the obstruction and the mechanical obstruction at the level of the aqueduct, with impossibility of the flow to go from the third ventricle to the fourth ventricle. And there are now many series that have been published. This exam of the literature stops in 2006, and you can see that many thousands of cases have been operated so far, and that the success rate is usually quite acceptable in all series, ranging from 87 through 83 to 72%, with an average of 75-80% of the cases. Only a few cases show that there are bad results in aqueductal stenosis. This series is from Canada, surprisingly from the Sick Children Hospital of Toronto, where they only had a 35% success rate with endoscopic third ventriculostomy, and also this other series from the, I think from the United Kingdom, it's from the other series. And these were quite surprising, and certainly there was something wrong in the selection of the patient or in the evaluation of the follow-up of this patient. But now it is quite well accepted that both in children and in adults, children above 1 year of age, the results are quite good. Remaining at 2005, there were 30 series in the literature, but now there are probably more than 100, ranging from 2022 to 94% of the success rate, with a mean of 68%. If we compare the results of the shunts, this is the great prospective randomized trial of the shunts, comparing the Sigma standard and the Delta valve, that was done in the 90s, where I participated when I was in Paris. This is the gold standard of shunt treatment in the 90s, and we overlap to this shunt results, the results of the series with the endoscopic third ventriculostomy. We can see clearly that the results are were a little bit better, especially in the very, very long term, where after 3-4 years, the results are relatively stable, both in children and in adults. Some cases, like the series of Tool in 99 or the series of Gartner in 2002, were a little bit worse, and now there is some idea that probably we should review in children below 1 year or 1 year and a half of age this vision, but certainly the long-term results remain much better in the endoscopic third ventriculostomy. What happens to these cases that fail after 1 or 2 or 3 years? We see that after 3 years the failure is extremely rare, but still can happen after 1 year, after 2 years and a half. Everybody agrees that ETV is a valid alternative to shunts in most cases of aqueductal stenosis, but this statement remains still to be proven by a prospective randomized multicentric trial that remains very, very difficult to be performed, because now in obstructive hydrocephalus above 1 year of age, the indication for ETV is relatively formal and quite widespread accepted, and would be unethical to propose a multicentric randomized trial in ETV. What happens to these cases? What happens when patients fail after 2 or 3 years after endoscopic third ventriculostomy? If we look at the single case, it is usually related to the closure of the stoma. This is the preoperative cases, this is the post-op. Probably the hole was not large enough, and this is the case 1 year later, with a recurrence of the hydrocephalus, closure of the stoma, disappearing of the flow artifact, and the clear evidence of obstruction of the stoma. What can we do when the stoma recloses after 1 year, after 2 years? Is reopening of the stoma still an alternative to shunt? Well, there are series in the literature that prove that the success rate is relatively good in children above a couple of years of age, and that the results are much worse if the child is below 2 years of age. So whenever you have an occlusion of the stoma above 2 years, please try again your endoscopic third ventriculostomy again. In the Naples-Turin series, that is the largest series of reopening of endoscopic third ventriculostomy in 40 patients, we had a 75% success rate, and this was published in 2008. This is in this series of 40 cases, this is the permeability of the primary ETV. You see that most of the failure was in the first 3 years of life, and these are the results following the second ETV, with 2 cases requiring 3 endoscopic third ventriculostomy to be fully functional in the long term. And of course, there was a significant difference in children. When we find adhesions at the level of the cistern, in the prepontine cistern, of course, things do much worse if compared to the clear cistern, where we have absolutely no problem. And also the difference is very significant below 2 years of age and above 2 years of age. So in case of delayed closure of the stoma, secondary ETV is rational, indicated with a 60-70% expected success rate above 2 years of age. Post-hemorrhagic hydrocephalus. Post-hemorrhagic hydrocephalus, as you know, is a multifactorial form of hydrocephalus. We can have aqueductal stenosis due to the organization of the clots, but we can also have clots in the subarachnoid spaces. So we can also have some form of communicating obstruction at the level of the cistern or at the level of the cranial vault. So it's a multifactorial form. And historically, there are many cases proposed as an alternative to shunts, like external drainage, subcutaneous reservoir, ventricular subgaleal shunt, endoscopic ventricular lavage, or third ventriculostomy and CPC. Our experience was very bad when performing third ventriculostomy in the acute phase, with 100% failures when performing the acute case, but some cases were very good after the shunt. For example, this case, of course, it's tetraventricular form. You can see that the fourth ventricle is very much dilated. He was shunted, and representing with the shunt malfunction, a couple of years later, you can see that there is a shunt that is not functioning, but in this case, there is a obstructive form with a normal fourth ventricle. So this is a secondary acquired aqueductal stenosis, and this patient went very well with the ETV. So you can perform ETV during shunt malfunction in cases of post-hemorrhagic hydrocephalus. And in the primary cases, post-hemorrhagic could be considered as a contraindication to third ventriculostomy, but probably in other cases, it has been proposed that the ETV associated to the choreoplexus coagulation could be performed better if compared to isolated ITV, and this has been proposed by Ben Wolf in the United States, and there are now several cases, but still the results are not so good, and this remains some form of thing that should be proved yet, because the results are not very good with 40% success rate. When we look at the preliminary experience that has been done, not in Africa like in Ben Wolf, but in a developed country with a different form of epidemiological hydrocephalus, no more post-meningitic hydrocephalus, patient who survived meningitis, neonatal meningitis, but patient mainly with obstructive form or post-hemorrhagic form, and they review their results. They saw that they had 50% success rate when that was highly dependent on the extent of choreoplexus coagulation. The largest the choreoplexus coagulation, the best the results. So the extent of CPC can affect the outcome when you combine ETV and CPC. In posterior fossa tumor, this is a good indication to the ETV. Of course, there are several forms of management of hydrocephalus. We have external ventricular drainage, early surgery to remove in emergency the tumor, or endoscopic third ventriculostomy. Ashoff, in his review of the literature, 14 papers, he reviewed very nice review in 1999. Out of 749 patients, he found a lot of complications that were related to preoperative ED. 7% of infection, 0.3% of hematoma, 0.7% procedure-related mortality. That means a very high mortality related only to an EVD, and 20% of final shunt. So preoperative EVD is not a very safe procedure to manage hydrocephalus in posterior fossa tumor. Surprisingly, he had only 0% of bleeding and 0% of upward herniation that are classically considered as typical complication of preoperative EVD, but in his case, the most frequent complication was the hematoma, infection, and other forms of mortality-related cases. When we look at the results of third ventriculostomy in posterior fossa tumor, classically from the very pioneer work of Jones, it has been proposed in a posterior fossa tumor, and it is certainly effective. And even the School of Paris, from the first work in 1998, they reviewed their cases, and they found that the results of ETV in posterior fossa tumors are quite good. It is an obstructive form of hydrocephalus, of course, because there is no, in cases like this, even if the tumor is outside the fourth ventricle, there is a clear obstruction of the outlets of the fourth ventricles. It is an obstructive form of hydrocephalus, and ETV works very nicely. It can be difficult to perform it because the floor is very close to the basilar artery, and basilar artery is pushed upwards, so technically can be more difficult, but it is usually possible in all cases of posterior fossa tumor. It works very well. This is a preoperative cases, and this is a post-op where the tumor is still there, but the ventricle are much lower and without ependymal resorption. Of course, after you have to remove the tumor, but hydrocephalus is managed very effectively before surgery. Another case when we still have the tumor, this is an ependymoma with an obstruction of the foreventricle of the Magendie foramen, and you can see that the hydrocephalus has been effectively managed with an endoscopic ventriculostomy. So in case, of course, the treatment is tumor removal. Of course, we are not joking with this, but in any case, you need to manage hydrocephalus in emergency before tumor removal. ETV is a good alternative to endoscopic, to the external ventricular drainage. Certainly there is no consensus, but there is a good possibility if you want to perform an ETV in posterior fossa tumor that it can manage hydrocephalus effectively. Tectal tumors are usually very, very indolent tumor. Here you can see the quadrigeminal plate that is enlarged by this infiltrating lesion. Sometimes they can be very big and still remaining very, very slow evolution, and this also is a very obstructive form of hydrocephalus with the aqueduct that is completely disappear and occluded by the tumor, and the flow that is bulging downwards into the prepeduncular system. The clinical presentation is usually limited to the hydrocephalus. There very rarely there are other neurological signs, and they remain stable over time. So we all know since the 90s that these kind of tumors should rarely be treated because rarely require treatment. They only require treatment of hydrocephalus, only follow-up MRI in the very long term, and we have to perform surgery or radiotherapy only in the rare case of evolution that is not higher than 20% of the cases. So be very careful in the surgical indication to the tumor, but of course treat the hydrocephalus with the endoscopic third ventriculostomy. Tumor biopsy is rarely required. Pineal tumors. Pineal tumors are another wonderful indication of ETV, and since the early times from Ferrer has been indicated as a really a royal indication for endoscopic third ventriculostomy. Obstructive form of hydrocephalus. Aqueduct is completely occluded by the tumor, and the hydrocephalus is very nicely managed by the endoscopic third ventriculostomy. And during the ETV, you can also perform a biopsy. Binary region tumor can also be performed in cases of normal ventricles, and it has been proposed by the School of New York that biopsy should be performed with a double trajectory. One bar hole that is located here as a standard ETV, and one much more anterior bar hole at the level of the hairline in order to get a good trajectory to perform a tumor biopsy. In fact, this can be, you can go either below or above the massa intermedia, but in fact, if you perform an intermediate bar hole, a couple of centimeters anterior to the coronal suture, you can perform both the ETV and the tumor biopsy effectively, and there is no problem in doing that. Like in also in this case, when the tumor is very much posterior, you can either use 30-degree optics, and rotating the optic, you can have a good vision of the tumor. Either in this case, for example, you can see that with the anteriorly located optic, we do the ETV, then we rotate our optic of 30 degree, and we have a very nice vision of the aqueduct region, of the posterior commissure, of the interabennular commissure, and we can perform, this is a tumor of the aqueduct, but also tumor of the pineal region can be biopsied very, very effectively, and you see that there is a very good manipulation. Steerable fibroscope can be used to perform biopsies of the pineal region tumor also, and the vision is certainly less good, but this is the pineal tumor that can be biopsied with a fibroscopic, with a steerable fibroscope, and the biopsy can be very effective also, even if the sample are smaller if compared to rigid endoscope. So in pineal tumors, there is a key role of neuroendoscopy for management of hydrocephalus, CSF sample for markers, and tumor biopsy. And can do that in most of the cases with a single bar hole technique, with an intermediate bar hole, a little bit more anterior if compared to the standard ETV. Myelomeningocele patient, the initial experience with in the acute phase, a very bad experience with very, very young babies, but when performed during shunt malfunction like T and Jones, it has been considered as a good indication with a 72% or 75% of good results. And Wolf in 2005 in an African setting, performing ETV only, had only 34% of success rate, but when he associated ETV plus coronary plexus coagulation, he obtained more than double of good results in myelomeningocele patients. So in an African setting, certainly the association of ETV plus coronary plexus coagulation had very, very nice results in myelomeningocele patient, and this should be kept into due consideration. And this procedure is now considered as a standard of care in the United States for most of the cases of myelomeningocele in the acute case. Technical pitfalls, the anatomy of the frontal holes are different. There can be a genesis of the septum, small foraminal Monroe, very large mass intermediate that could make impossible the progression of the endoscope, and also the anatomy of the floor of the third ventricle is a little bit different if compared to standard. So there can be higher rate of technical failure. Like in this case, for example, the floor is very thick, massa intermedia is very large, and we cannot see where the foraminal Monroe is with the trigon that is a very complex structure, and the very small third ventricle. Or like in this other case where there is a very, very strong deformation of the floor adherent to the clivus with a very large massa intermedia, impossible to perform an ETV in cases like this with a very shallow posterior fossa. So there is certainly in myelomeningocele a higher rate of technical failure that can approximate up to 30%, and sometimes you just enter and you see that you realize that you cannot do anything. Now with the good MRI you can avoid entering the ventricle to check, but certainly there is some case where it is impossible to perform ETV. Lower success rate in the newborns, as we said, but 76% of success rates if you associate coronary plexus coagulation, and certainly there is a higher success rate during shunt malfunction in children and adolescents. This is a very good indication. You have a myelomeningocele patient coming back to you with a shunt malfunction. You can perform an ETV, remove the shunt, and you have an 80% success rate in cases like this. So endoscopic third ventriculostomy is a valid alternative to shunt revision during shunt malfunction and in older patients above 6 months of age. And ETV plus CPC certainly deserve further consideration. In case of shunt malfunction, as we said, it has been said that results can be very good when the patient comes back to you with a good indication, then you perform an ETV. This case, for example, with a shunt malfunction and with a triventricular hydrocephalus with a very large third ventricle, obstruction of the aqueduct of Sylvius, you can perform an ETV, you can remove the shunt. This is in the immediate postoperative period with a safety EVD. You leave a safety FDD, and this is 4 months later, is free of shunt, and he has no more hydrocephalus, just you have to check in with the follow-up MRI without any other problem. So in selected patient with triventricular dilatation during shunt malfunction, ETV offers reasonable chances of curing the hydrocephalus, allowing for shunt removal. Then the Walker malformation and occluded fourth tetraventricular hydrocephalus, you can have traditionally membrane fenestration or excision, or as an alternative, the endoscopic third ventriculostomy. The excision of the membrane, has been abandoned in the pre-shunt era because of the high failure rate, mortality, and morbidity, but recently has been reproposed for older patients or to treat complex shunt complication. In cases like this, for example, where you have a free aqueduct, but you have a complete occlusion at the level of the Magendie foramen because of the membrane of the cyst of the Dandy-Walker cyst, you can perform an ETV and you can have a very nice result. This is an obstructive form of hydrocephalus, and the resolution of hydrocephalus, flow artifact, floor, and you have the cyst that is completely decompressed, and you can avoid the shunt in the Dundee Walker malformation. But also in cases of obstructive tetraventricular hydrocephalus, like in this case, you have just occluded Magendie foramen, occluded Luschka foramen, tetraventricular form of hydrocephalus, difficult ETV in this case, but you can still perform it, and you can have a good result in this case with a nice flow artifact and resolution of the hydrocephalus without the shunt. And in other cases, for example, with the associated Chiari, we had very good results. You can see in cases like this can be a very good result for when there is a clearly obstructive form of hydrocephalus. Then you can have the intracisternal obstructive form of hydrocephalus, where you can see the dilatation of the Luschka foramen, like in this case, occluded the Magendie, and you also have occluded Luschka with the diverticulum of the Luschka with the membrane that occludes the Luschka foramen. This is an intracisternal form of hydrocephalus. This also is an obstructive form of hydrocephalus, and certainly you can treat that with endoscopic third ventriculostomy. Sometimes you can have obstructive form associating Chiari 1 and hydrocephalus, like in this case, there is an associated aqueductal stenosis and an associated strong Chiari 1 in a young adult, like in this case, you can perform an ETV. This is clearly an obstructive form of hydrocephalus, very complex form of hydrocephalus, but ETV can really resolve the case, and you can have a nice, you don't need the treatment of Chiari because this became completely asymptomatic, and you have a nice flow artifact at the level of the endoscopic third ventriculostomy in treating both the symptoms and the hydrocephalus. So in conclusion, the endoscopic third ventriculostomy changed dramatically our vision of hydrocephalus and of its treatment. Many say that we still do not know how it works. Certainly, we are still discussing about how it works, but certainly it works in most of the cases where some kind of obstructive form of hydrocephalus is present. The chorial plexus coagulation was revitalized when our learning curve of ITV was not completed yet. CPC seems to increase the success rate in ETV in the so-called bad candidates, like in neonates with the myelomeningocele, and certainly this is a very nice contribution from Ben Worf. We still do not know if it works. We still do not know how CPC works in association with ETV. This is really a mystery, and we do not know if CPC is harmful in the long term. They say that dementia could be increased, dementia rate could be increased in the absence of proper chorial plexus secretion of fluid, but the conclusion certainly is that many other meetings will be necessary to understand these figures, and we welcome our meeting, and we greet Salman Sharif for organizing such a night meeting. Thank you very much, and I still invite you to our workshop on next year, in next year January. We can perform a lot of training, almost 25 hours of hands-on training on 24 working station with one tutor at each working table, and you certainly with a robot and with the endoscope system like endoscopy, and you can certainly have a lot of fun during these meetings, and I still invite you in next IFNE meetings. Thank you very much.
Thank you, Patrick. I just asked one question. Regarding this ETV plus CPC, you're using laser.
Yes.
Do you think laser is better than usual bipolar that everybody else has been using, especially in Africa?
No, I don't think it's better. It's just, it's our tool. It is reported to heat less the CSF. So there is less heating. But since we do the procedure under continuous irrigation, the fact that it is less heating is not so important. Just we have it, we use it, and just to make keep practice with the laser that is more effective in the under procedure. But certainly you can perform excellent chorial plexus coagulation with bipolar or monopolar, because I mean in Africa they use the Bugbee wire, monopolar Bugbee wire. It's a wonderful tool and it's very effective. So there is absolutely no need for the laser.
And these patients with myelomeningocele, this is acute hydrocephalus at birth. So you're talking about patients under 1 month of age.
Yes, yes.
And your results are as good as 76%.
Their results, it seems to be quite good. My personal experience is very limited and very bad. Yeah.
7 patients did well out of 10. Is that correct?
Yes, yes, yes.
So that's 70%. But
Yeah,
you know, you
70%
can't
is,
have that
is in
result
Africa. In Africa.
with you.
No, I have maybe 20% success rate.
Okay.
It's very much lower, but it's very good in hydranencephalic patient and in extreme hydrocephalus.
Yeah.
In those cases, very good because you can really coagulate completely the choroid plexus.
Sir, is there any experience of yours in use of the ETV success score in selecting patients for third ventriculostomy?
It is a very nice tool to talk with the parents. Okay, if you really are the ETV success score is very interesting where you have no experience with ETV and when you can globalize your results talking with the parents. Okay, but every indication should be individualized to the patient. Every single patient should be carefully studied. And when you have behind you 20 or 25 years of ETV experience, you can be much more precise if compared to the ETV success score. Okay, ETV success score says that in the first 6 months of age, you have bad results. This is not my experience when you are extremely careful in patient indication. If you have an isolated obstructive aqueductal stenosis, 2 months of age, 3 months of age, there is no associated malformation, no congenital hydrocephalus. That means that hydrocephalus is postnatal. You have the same results as in adults, and my results are 70% of success rate, even in newborns. So this is very good if you have no experience, because certainly there are some tricks. You know, in small babies, there are very frequently multifactorial events. Some things that happens during the in utero. The neuroradiologists that miss some associated malformation and some prenatal or neonatal hemorrhage that contribute to hydrocephalus that has been overlooked on the, you know, so I do not trust finally what said is a very, very large series, because those people are, and this happens in very many multicentric trials, those people I think are not selected properly as isolated aqueductal stenosis without any other form of hydrocephalus. If you select very nicely your patient, you can have good results even at 1 month of age.
So we have a lot of patients in pediatric age where there's a shunt malfunction.
Yes.
We put in a shunt and it blocks, then we revise the shunt and it blocks. The role of ETV in such patients?
We are, it depends on your population of shunt malfunction. At the beginning of your endoscopic experience, you may have up to 30–40% of patients coming with shunt malfunction that are good candidates because they have aqueductal stenosis, because they had obstructive form of hydrocephalus. And then you select your patient, you perform ETV, you remove the shunt, you leave a safety EVD, because when you remove the shunt, you must leave a safety external drainage, at least for 1 week. And then during the first week, 10 days, you wait for adaptation period to go by, and then you can remove the EVD, you close the EVD, you test, and if it's doing okay, then you remove the EVD and your patient is cured. But you must leave an external drain, a safety external drainage, because otherwise you take a lot of risk. If you just remove your shunt and you close and you send the patient into the world, the patient can die during the night because he has a very acute hydrocephalus. So you must leave a safety EVD. Okay, if it doesn't work, at least you are safe and you can open it and you can put a shunt after 10 days if it doesn't work. But at least don't take any risk. Leave a safety EVD.
So very briefly, your experience regarding the aqueductoplasty.
Yes. We do not perform aqueductoplasty, never, except in cases of isolated foreventricle. In aqueductal stenosis, there is one guy who proposed the aqueductoplasty, was Henry Schroeder, and he was incredibly honest. He proposed the technique, and after 10 years, he said, don't do it because it doesn't work. there is the high rate of occlusion and high complication rate. So don't do it and perform ETV. But aqueductoplasty is very good when you have an isolated foreventricle in cases of multiloculated hydrocephalus. In these cases, performing an aqueductoplasty and leaving a stent through the aqueduct is a very effective form to treat this form of multiloculated hydrocephalus. Okay. Okay.
Just to follow on that theme, just a quick technical note. I think Pepe has covered everything, so I don't have to go into details of ETV at all. So when traditionally we are taught that, where are we going to put our borehole in ETV? Naeem, where do you put your borehole in ETV? So generally it's recommended pre-coronal borehole,
yes,
1 to 2 centimeter in front of the coronal suture. But, so that's the whole question. So basically, if you're looking at over here, the problem is that you've got blockage here, and you've got this triventricular hydrocephalus, and fourth is small, and this is the problem. And when we do ETV, basically we are bypassing from here all the way up till here. So when you bypass, obviously these ventricles go down and your circulation goes back to normal. This is from Harold Rickett, and I think this is probably from a few years ago. I'm not going to go into the indications. I'm not going to go into the age. We have already discussed that. Assessment. It's important. You need to know if the prepontine systems, along with other basal systems, and there is enough flow going through. Patients with good sized ventricles, good foramen of Monro, third ventricle, well-formed prepontine system, they are good candidates. Patients with large intrathalamic adhesions, as we talked about, small prepontine system are not ideal for ETV. And predictors of success, obviously various predictors have been shown. Preoperative third ventricular bowing, that's showing that the ventricles have high pressure, enlarged supraoptic recess, anterior curvature of the lamina terminalis, increased dilatation of proximal aqueduct and the distal, posterior bowing of the suprapineal recess, and then patients with image-guided surgery or perioperative steroid treatment were 2.5 less likely to experience failure. So we're going to discuss this regarding steroid after this. This is a paper from this was then published in Neurosurgery, and I can't remember, it was 2017 if this paper came out. Equipment, not going to go into that. So ETV generally is recommended that you make a borehole 1 to 2 centimeter anterior to coronal suture, and you pass a rigid scope, as we've just seen, and this is what we do. And opening is membrane, and the membrane is made by whatever you're comfortable with, and you may dilate it with either Fogarty balloon or crocodile, whatever you want. Obviously, the visualization during procedure can be worsened by bleeding, and if you've got blood in the CSF, then it's difficult to know where we are going. And in these cases, we realize that if you use neuronavigation, you can choose the most appropriate trajectory from entry point to the skull all the way down to the third ventricle. And this is, the important thing is, what is around foramen of Monro? Fornix. If you injure fornix, what happens? Yeah. And so I think it's important that you should have a clear, safe entry into the foramen of Monro. It may be small, it may be big, but you need to plan it beforehand. So if you do an inappropriate placement of borehole, if it's not in the right place, you can manipulate the foramen of Monro, you can have fornix in trouble, and then you may have difficult visualizing where your main target area is. So that is very important for us. So an optimum borehole can minimize the movement of endoscope at the level of foramen of Monro by trajectory from borehole to the foramen of Monro, but anterior movement of the ETV and posterior movement of the thing itself are equally distributed. So if you want to take a biopsy, as Pepe had shown, if you want to take a biopsy and ETV at the same time, you take the middle approach. So you can take it front and back equally and not cause problems one end or the other end. So if you look at this, your trajectory, what you do is when you are on your image guided system, you plan, you put one dot, one entry point on your foramen of Monro, center of it where you think you should go, one point where you think, whoa, in the pre-pontine system where you think you're going to make the opening, and join these two together. And once you join these two together, you just extend it laterally. So your trajectory is way behind than the trajectory generally that you need. So there are two ways you need to look at it. And if you're looking at laterally, again, you have to have optimum trajectory, that your entry point. So what you do is when you plan, you put one dot here, okay, and just extend this. This is your entry point. So this is your lateral extension. So basically the whole idea is that you don't cause any problems coming in to this area or to that area. So all that has to be properly managed. So you need to know where exactly you're going. Otherwise, if you manipulate and if you're not sure, and if you haven't been in the wrong place, if you haven't been in the right place, then you're ending up here. So you end up pushing the fornix on both sides and causing problems. So trajectory in the anterior-posterior plane and the lateral plane has to be perfect and has to be planned beforehand if you want this to be perfect. And when we did this, we realized majority of the time we were post-coronal. We were on average 4 centimeters behind where, according to where the recommendation was, nearly always. And once we realized that we thought we should look this up. So in freehand approach, burr hole is at a fixed position. It's usually not an ideal trajectory. And if you correct it inside in the third ventricle, you can cause problems to the fornix, as I'll show you later. So the need for ideal burr hole, one which considers the passage from foramen of Monro to the premammillary body, has been stressed in literature for many years. So mean ideal burr hole in this paper, they did the same study, and what they did was they found that the mean ideal burr hole was about 9 millimeters behind the coronal suture. It's post-coronal burr hole that you need to make. And they realized that there was difference of more than 6 centimeters between the most anterior and most posterior ideal burr hole position. So it changes depending on what the pathology is, what kind of ventricles we have, what kind of foramen of Monro we have. Sometimes fornix are big, sometimes small. So mean ideal position of the burr hole was always slightly posterior to the coronal suture, with considerable variation in the position of the optimum burr hole, stressing the need for a patient-specific planning. I'm not going to go into that since it's been shown. I'm just going to show you how we do this. So this is a patient complaining of gait disturbance, actually an NPH that we did. And I'm just going to pause it here if I can. Yep. So what you do is you plan. So when you plan, you have to go exactly in the trajectory of, when you see foramen Monro on the coronal plane, and then you go all the way to where you're going to make the opening. So all that has to be correlated. So this has to come exactly where the foramen is. So this is going to go back in here so that we have a direct line, direct trajectory coming in. So you have a trajectory, two-way trajectory. So AP direction as well as lateral direction. You have to correct that. And once you do that, you plan accordingly. And we will let it play. So what happened, we planned this really nicely, but the burr hole made by my friend was slightly anterior to what we decided the trajectory was. And you'd see what problems we can give then. So although we decided, so it was this coronal suture, and this is where we thought was the optimal trajectory, but we went in and we made a hole slightly more anteriorly. So we are starting out anterior to where we thought we should be. So what did we do? We went in, we did our third ventriculostomy. The foramen was very small. So we went in there, we found the mammillary bodies were actually, if I take you back. So, oops. So you can see the mammillary bodies are where? Right in front. So when we are going, we need to make a hole underneath over here. So our trajectory is incorrect. And the reason is that although we planned everything, but the burr hole was not made in the place where it should have been made. So when we go in, we do our ventriculostomy. So I'll take it forward. We did our ventriculostomy. And then what did we do to the fornix? Can you see this?
Interesting. Small.
We have a small contusion there. So why? Because we had to retract it, our manipulation inside anteriorly. So that's why it's so important. So this was a teaching video that came out from a mistake. So I think it's very, very, very important to plan this. I'm not going to go into the complications and various things, but it's just that many of these, I'm not going to go into that. This is actually Lake Cephalmuluk during the winter time. And it's amazing scene. Anyway, any question? Pepe, you're on next again.
Why the trajectory is posterior by this navigation?
Thank you, Salman, for the very nice review of the reason of performing a nice and well-positioned bar hole because really starting the procedure well is the most important thing. And now we will talk about something a little bit more advanced, the endoscopic management of intraventricular tumors, starting from the small biopsies until the removal that we can perform. The limitations of traditional endoscopy in intraventricular tumor removal traditionally are there is very small working channel, so it's very difficult to remove a huge tumor through a small working channel, small forceps. It's a long and boring procedure. There is a blurring of the vision due to the fact that the tumor is bleeding when you remove it. And traditionally, it was limited to tumor below 1.5, 2 centimeters. But even a tumor of 1.5 centimeters that is traditionally very small can be incredibly huge on an endoscopy and can be very difficult to be removed under endoscopic procedure. We can perform tumor procedure in pineal, third ventricle, lateral ventricle, posterior fossa, in craniopharyngiomas, and in forms of cystic tumors. So we will see one by one those cases. Pineal, we already talked about management of brain tumors in the pineal region with the neuroendoscopy. So let's talk about tumors in the third ventricle. This was a case of many years ago, more than 10 years ago, a boy of 15 years with a pilocytic astrocytoma of the third ventricle. And this was the situation more than 10 years ago. Very nice beginning of the procedure, a tumor that was floating. And after the first coagulation and bites, you start to have bleeding and bleeding and bleeding. And this is the end of the procedure with the vision that is completely blurred by the tumor. And so you spend 1-2 hours and you can remove completely the tumor, but it's very, very long, very complex procedure and certainly not ideal, and the instrumentation really required some improvement and this was an ideal case because it didn't bleed very much and it was floating into the third ventricle. So limited to very rare and exceptional cases. Lateral ventricles also, before the advent of these new tools like the navigation, the thulium laser, the endoscopic Travitron, and the dry technique, the situation was quite complex, but certainly we could manage small tumors of the lateral ventricle endoscopically. Like in this case, for example, very small, tiny metastasis of an ependymoma in the normal ventricle. With navigation, we can enter into the normal ventricle. We can see, look how big looks this small metastasis, and even the small metastasis can bleed very much. In small ventricle can be, it took almost 1 hour to remove it completely piecemeal because it was bleeding and because we had only small forceps and it was a small ventricle, so under continuous irrigation. So a long time we really needed other tools to improve our performances in the management of intraventricular brain tumor. You see that the removal is complete and under navigation we can achieve a perfect orientation. The next step finally occurred in, it appeared commercially approximately 10 years ago, but finally it remained embedded in very, very few departments and very, very few people were using it. So we're starting to use it 5 years ago, and it really changed our vision of our vision of possibility of performing something in intraventricular tumor. This is the way it is used with a GAB endoscope. It can only be used through a GAB endoscope. It is quite long, and our experience is 17 pediatric cases, 10 intraventricular, 3 paraventricular, and 4 suprasellular lesions. We started in 2013. We have recently published a few months ago our beginning experience with this histology: 3 SEGA in tuberous sclerosis, 2 OPG, 6 glial tumors, 2 craniopharyngiomas, and other different tumors. In 15 cases, we used the pre-coronal bar hole. In 1 case, a parietal occipital, and in 1 case, a more frontal anterior bar hole for a more posterior third ventricle tumor. Surgical technique, we have to do it in continuous irrigation with warm Ringer lactate. We can keep a low aspiration power, 15-20% is enough. We have to remember that this is an aspirating device. If you suck CSF from the ventricle, you have to replace it immediately. So you have to operate under continuous irrigation. Otherwise, you just use it for 5 minutes, you have an acute subdural hematoma, and the history is over. So you have to operate under continuous warm Ringer irrigation. This is mandatory. Cavitation power instead can be adapted to tissue. You can run from 20 to 80%. It depends if the tumor is soft or is harder. And you need a direct control of the suction tube with possibility of immediate clamping. You need an assistant with a clamp on the tubing ready to stop the aspiration in case you are aspirating some blood vessel or something that you don't want to aspirate. These are the very simple setup, quite long stuff, but you can manipulate quite well with one single hand, and this is the way we use it. As I show you, a single standard bar hole, pre-coronal for this is a case of subependymal giant cell astrocytoma, standard bar hole, introduction under navigation with the pneumatic arm of the trocar into the lateral ventricle, small ventricle, but still, no, I mean, there is a mild dilatation, so it's you need a navigation to introduce your trocar. After the introduction of your trocar with the electromagnetic navigation, you remove the stylet, you fix the arm, and you introduce the optic, of course, and after the optic is secure, then you can adapt under control of the vision your position in order to get closer to the tumor, and then you introduce the cavitron into the working channel, and you start to aspirate the cavitron with the cavitron, as you will see in the next images, starting from the very superficial part of the tumor after some coagulation if necessary, and you can manipulate things with both hands, and it is very easy, but we can perform a procedure on smaller tumor even if freehand, and this is the way we hold the whole stuff. In the tumors of the third ventricle, it is especially effective. This is a larger tumor than usual. This is 2.5 centimeters. This is completely occluding all the third ventricular tumor, bulging into the lateral. It is an ideal case because a very large, huge lateral ventricle bulging into the right lateral ventricle with a strong calcified component. So you can imagine that this is not a good candidate for endoscopic removal, and this is the way it appears, and this is the way you started to use, even without coagulation, we start to use and we start to suck. This tool is sucking the blood out. So you can, at the beginning of the procedure, you keep the field very clean. You see that there is no blood. You don't move your endoscope too much. So you continue to aspirate the blood into the sucking device. You have to coagulate your choreoplexus, otherwise your choreoplexus is attracted into the cavitron, and you can continue to remove it. You see, this part is very easy because it's not bleeding very much, but when you start to approach to the deeper part of the tumor, to the core of the tumor, then it becomes more bloody, so you have to get closer and you start to aspirate also the calcified part. You have to increase your cavitation power up to 80-90%. You saw that you can fragmentate your tumor. And this is quite a long procedure. It can last up to 2 hours, certainly shorter if compared to a standard craniotomy, but certainly you can remove it completely through a single bar hole, a single bar hole technique. At the end of the procedure, the bleeding is controlled much better, and you can have a subtotal removal with just a very, very small remnant below the anterior commissure, and this is the postoperative MRI, and also the calcified part has been completely removed, and this patient is stable since 8 months with a very small residual. This was another very large tumor that was half intraventricular and half intraparenchymal, very close to the pyramidal tract. So we decided, this was one of our first cases, we decided for an enlarged biopsy to check what it was through the ventricle. And we found that finally, in this case, we discovered that the potentials of this tool, that the ventricle was not very large, but we found a very soft tumor, not very vascularized, very easy to suck. So it was really very, very easy to remove the intraventricular part completely in one single procedure that lasted a little bit more than 1 hour. So we had an enlarged biopsy, and we realized that finally the potentials of this tool, we can identify very nicely the limit of the tumor. Here we are removing the closest part to the ependyma. We can identify very nicely the limit of the tumor if compared to the ependyma. This is the upper part of the tumor that is removed. You see that it's not bleeding very much. Certainly we had very advantage by the fact that the tumor was not very much vascularized, but you see that the magnification is excellent. The limit with the ependyma are very nicely recognized, so you can avoid even probably somehow even better if compared to this is the limit. You see, this is the tumor, and this is the limit with the corpus callosum, and you can identify very nicely the boundaries. And this is at the end of the procedure. This was the first procedure. We removed half of the tumor intraventricular. It was a low-grade tumor, so we decided to go back, and through the same bar hole, we were able to remove it completely. This is the pre-op, and this is the post-operative following the second procedure. In tuberous sclerosis, also very nice indication. Small intraventricular tumor at the level of the foramen Monroe. Sometimes you don't want to do a callosotomy to perform, to remove such a small tumor. Sometimes they have either removed them, and the cavitron is very nice tool to remove it with a minimal invasive procedure. In 30-45 minutes, you can remove this tumor. They are much harder, they are more vascularized, they are more firm if compared to the low-grade glial tumor that are typically into the lateral ventricle. But this is nice to show that we can remove the lowest part of the tumor. This we are looking backward into the body of the lateral ventricle. You see the cavitation of the tumor, and even we can perform some nice dissection of big veins. In cases like this, you have a big thalamus striate vein. You see, you have big thalamus striate tumor that is adherent to the thalamus striate, and you can perform a very nice dissection, very careful dissection with a good control of your aspiration, and you can suck completely out the tumor from the low thalamus striate vein, and you can free the foramen Monroe. And this is the result. Of course, we did not address the left tumor, only the right side of the tumor, and it was a complete removal. Craniopharyngiomas can be very frequently cystic. In this case, with infiltration, you can either go endonasal, but you can also have a very nice subtotal removal with the endoscope when there is a very large cyst into the third ventricle. You can go transventricular, you can go endonasal, of course, but transventricular, in cases like this, you can do palliative surgery in adults, but still you can perform endoscopic removal. When you have a case like this with the solid part in the infundibulum and the cyst into the third ventricle, you can perform, first of all, coagulation of the choroid plexus, so you don't have choroid plexus to bother you, and then you attach the cavitron to the cyst. You suck immediately in a few seconds the whole content of the cyst, so you don't have a spillage of fluid into the lateral ventricle, and you remain with a clean CSF, and you see that you don't move your cavitron at all. You just let the cavitron work. We are lazy people, we don't want to work very much, and we just leave the cavitron work for ourselves. it is aspirating, it is fragmenting the tumor. You don't have to move your cavitron like a crazy, as like some people do in microsurgical activity. You just leave your cavitron work. You see that you can aspirate only the part that is floating into the third ventricle. You don't go to scratch the tumor into the hypothalamus, because otherwise you will have problems. Here you are into the third ventricle, you are identifying the membranes that you can dissect and the part that is instead infiltrating the hypothalamus. You want to remove as much tumor as possible, and here you can clearly identify the tumor that is floating and that can be freely aspirated, and you can stop at this level where there is infiltration of the hypothalamus. So don't push your removal within the hypothalamus. You can remove and fragmentate nicely the membrane that is floating into the third ventricle. You can recognize, you see that it is very hard, it is calcified, but if you improve and you increase your cavitation power, you can remove very nicely this hard membrane. You can recognize the mammillary bodies, you can recognize the attachment of the tumor at the level of the hypothalamus. You see, you can avoid to enter the hypothalamus and fragmentation of this very calcified part. And so this is just to show that you have to be patient, and this is a 2 hours procedure through a single bar hole. You do not harm the hypothalamus. You remove 90% of the tumor, and you leave the infiltrating part that in childhood, it is now a general agreement. You see that you can still remove this floating part, avoiding to remove the part that is infiltrating the hypothalamus. The infiltrating part should be treated with radiotherapy. It is a much more effective tool if in children who are not completely developed under the hormonal point of view, and it is a safer method in the very long term instead of a complete aggressive removal. Here we leave a small fragment of tumor infiltrating the hypothalamus that is removed endoscopically. In other cases, we were able to remove tumors completely. Optic pathways gliomas. Optic pathways gliomas, we know that surgery is a limited option because the real treatment is chemotherapy and radiotherapy. In these cases, you only have to restore the fluid between the foraminal Monroe and the aqueduct of Sylvius, so you can remove the tumors that is in the posterior part of the third ventricle. After the biopsy, we can remove, you see, into the foraminal Monroe more and more tumor with this cavitron, and we can isolate the posterior part of the tumor, so we can create a good communication, and we can recreate the CSF pathways. You see that we are aspirating only the posterior part. We irrigate, or you can see progressively coming down the ventricle, but if you restart the irrigation, you go posteriorly, and you remain posteriorly, you aspirate more and more tumor until you find finally the aqueduct of Sylvius. Here you are into the third ventricle. This is the massa intermedia, and you can aspirate progressively the tumor until you identify the aqueduct of Sylvius that is behind the posterior pole of the tumor. Here you are aspirating this part, and you see that progressively the aqueduct of Sylvius will appear, and you know at this time that you are freeing your CSF pathways. Here you have the aqueduct, and this is free. So your job is done. You have removed the superior and posterior part, and you have freed the upper part of the third ventricle, and your CSF can circulate. But you can even do, when you have a very, very big tumors, like in this case, you can perform a very, very large removal with a complete free of the posterior third ventricle, complete freedom of the aqueduct and of the foraminal Monroe, and send this patient to chemo and radiotherapy, and he will be effectively treated like that with one single bar hole technique. And this is the pre-op of one of such cases, and this is the post-op after endoscopic removal with the cavitron with 80% removal and sent to chemo and radiotherapy. Cystic tumors can also be good candidates, like cystic relapse of OPG. When you have big cysts like this, you can coagulate them with monopolar, with the bipolar. You have a very big cyst floating into the lateral ventricle. We can catch them if the cysts are small, like in this case, but sometimes the cysts are much larger than this, and then you can first of all you see that we are removing a lot of this tumor cyst into the lateral ventricle. Sometimes the cyst is so large that you have to coagulate it before with the laser or with the cavitron or with the monopolar coagulator, so you can shrink them, and after significant shrinking and separation from the ependyma, you can do that with the laser, but monopolar is as good. In this case, laser with a pulsed power certainly was extremely effective, and after complete shrinking of the cyst, they are grasped very nicely and removed completely with through the endoscope, and this is the post-operative with complete removal of the cyst. And in some cases, this of course is not this giant ependymoma. Of course, you cannot remove it endoscopically, but sometimes after 2 surgery, very big microsurgical procedure, you still have some remnant along the ependyma of the contralateral horn, so you don't want it is hidden to the microscope vision because it is below the corpus callosum. You cannot reach with the microscope, so you need an endoscopic vision. And in these cases, for example, it was a very bleeding tumor, very attached to the ependyma. We started to remove it with the endoscopic cavitron. In these cases, we were obliged, due to the very severe bleeding, that is not very important, but it is sufficient to completely obscure your vision, to remove the fluid and working in the air with a dry field technique. When this technique is very nice, of course you have to inflate air into the ventricle to avoid ventricular collapses like we do in in the belly for laparoscopic surgery. And you see that you can be extremely precise in a tumor removal, even in a dry field. This is quite a long procedure because the tumor was very extended over a surface that was very large. It lasted almost 3 hours of procedure to do endoscopically, but we were able to do through a single bar hole, and it was very nicely done. And finally, the final result was, as you see, that the complete removal of the tumor infiltrating the ependyma was achieved, and the patient was sent to chemo and radiotherapy with a much better prognosis because of the complete removal. So we had a very nice result with nice complete removal and 6 planned partial removal. The procedure is easier in larger ventricle, but possible in normal ventricle under navigation control and continuous irrigation. And the strict control of aspiration power is of utmost importance. We had a complication, 1 subdural hygroma treated by subdural peritoneal shunt. In conclusion, patients harboring intraventricular tumors are in most cases ideal candidates for endoscopic biopsy resection. Endoscopic cavitron is very effective in selective indication. Potential to expand indication to pure endoscopic resections is possible, and a specific training is necessary. And of course, you can achieve a specific training in our workshop where you will see endoscopic cavitron and you can use them on rat models. Thank you very much for your attention.
Sir, what are the techniques to control intraoperative bleed endoscopically?
What are
the tools and techniques to control intraoperatively?
Irrigation. Irrigation is
endoscopically.
Irrigation during the endoscopy is the most effective tool to control the small bleeding, because 90% of these bleedings are very small and they can control with continuous irrigation. Otherwise, if you have a single small artery or a single bleeding point, then you can control easily with a coagulation or with monopolar or bipolar or with the laser. Otherwise, if you have an emergency situation with or excessive bleeding, like the last case, in this case, you can remove the CSF and work in an air environment, a dry field technique. And by the moment you remove completely the CSF, the bleeding immediately stops. And then you can just wait. You can continue in a dry field technique like we did, or you can refill your ventricle with a normal Ringer lactate. It's a very effective method.
In one of your case, I think that of craniopharyngioma, you use cavitron, and it was sort of blind. Like when you think that your procedure is complete, the tumor is completely removed,
It's not blind, not blind technique. You always must have a visual control of what you're doing. It is mandatory. You cannot introduce your cavitron blindly. I mean, you aspirate your fragments, and then you follow the fragment until the insertion on the ependyma. And you can remove the tumor until it gets into the ependyma, and you know that it's entering and infiltrating the hypothalamus. And then you stop under visual control, always under visual control. It's never blind, never blind technique.
Okay.
First of all, it was a very good surgery, and it was fascinating. But there is one question in my mind, that the craniopharyngiomas are mostly very adherent tumor, and you were moving very easily. Is it possible to remove whole of the capsule of the craniopharyngioma in this way, or we have to leave the part of it?
Is like in microsurgery. There are craniopharyngiomas that are very easy to remove completely, just pulling the membrane because the adhesions are very small, and there are craniopharyngioma that are very much infiltrating. I had another case of craniopharyngioma that was removed completely because it was much easier to dissect the membrane from the ependyma of the third ventricle. But in the first case, the infiltration of the hypothalamus was excessive, and I prefer to avoid hypothalamic damage. In children, it is very important not to, it is always easy, it is always possible to remove craniopharyngioma completely, okay? This is not a matter of, is it possible or is it impossible? The problem is that in children, we cannot push our resection too much because the damage to the hypothalamus can be excessive. And if you push too much, your patient can be obese, can have hyperphagia, can have hypothalamic syndrome. So it is better to do a subtotal removal and do an irradiation of the residual in small children.
Okay, thank you, Pepe. That was very nice. Now we have Kim, who's going to be telling us about transforaminal endoscopy. What I was going to ask Pepe was putting in air.
Yes.
Is there any particular mechanism why you do that, or is there any scientific way?
When I have no, it's very off-label. It is very off-label. It has been described by Michael Gabb. It has been published recently in Child Nervous System with a series of 9 cases of colloid cyst where removal of the fluid was necessary to stop the bleeding. So it is published. And I do it with the cavitron. I aspirate the fluid, and at the same time, I inject air with a syringe in order to replace the pressure. Yes, yes. No pressure control. It is very much relying on your experience. Of course, you have to be very careful in doing that. But I had no problem. I did it in 2 cases, and I had no problem in this case.
All right, thank you. I think Kim is going to entertain you. I think we'll just go into theater and set up stuff. You should be able to see everything very nicely here. We have Bled here and Kim, who are going to be moderating, along with Zishan and Farhan, who are senior registrar and registrar. So they'll sit and make sure that you're able to see, and you can communicate, ask questions, and please direct all those questions to Pepe, since he's the senior surgeon in there. No, I wouldn't say the senior surgeon, but yeah, the most experienced surgeon in there in pediatrics. Okay, so let's start with Kim's talks. Whatever you want, you can change the way you want. If we have time, then you can have more talks with as well, which is for 10.
Salman, can I start now? Yes, please. Okay. Good morning, ladies and gentlemen. I'm Hyun Sung Kim from South Korea. It is very great honor to give a lecture in the skull-based workshop. Yes, this time my topic is the transforaminal endoscope, and the Salman give us some title as a which technique is better. I don't know what is the meaning of this technique, which technique is better. But anyway, I hope to some discussion about the transforaminal endoscopic discectomy, and but nowadays we have so many debates. Sorry. Okay, and nowadays we have so many debates in the endoscopic discectomy. I will discuss about that. Yes, the percutaneous endoscopic discectomy is last named. Nowadays we naming the percutaneous endoscopic spinal surgery. And there has two approach route in the lumbar spine surgery. One is the transforaminal, one is the posterior approach, and posterior and posterolateral approach. And we can classify the endoscopic spinal surgery. Last year, we performed the main kind of the microscopic assisted endoscopic spine surgery, but actually this is not full endoscopic spinal surgery. But nowadays, we perform the full endoscopic spine surgery. Full endoscopic spine surgery also can classify the two kinds. One kind is uniportal and one kind is biportal. Biportal usually using the arthroscope, but uniportal using the usually 30-degree uniportal endoscope. Uniportal also divided two kinds, intraforaminal and transforaminal. Today we will discussing that this transforaminal debate. Actually, why we performing the transforaminal endoscopic spine surgery rather than the intraforaminal endoscopic spine surgery? Yesterday, I already talking that the transforaminal endoscopic spine surgery before time we performing as a purpose to early recovery and early ambulation and less anesthetics. But nowadays, the purpose of the transforaminal is some changed. For in these cases, we can see that it's less than the anatomical structures and preserve the motion segment there completely and preserve the neurological stream there completely. That is the main purpose of the transforaminal approach rather than the intraforaminal approach. There has many debates, but most common debate is the inside-out technique and outside-in technique. What is the inside-in and outside-in? Inside-out technique means the first insert the working channel into intradiscal space, and after then find the protrusion disc and target point of disc. And outside-in technique, first only docking to the canvas triangle, after then find the target point, after then leave the ruptured target point or protrusion disc. But actually, this inside-out technique is seems like very easy, and the beginner is a very easy technique. But unfortunately, it has some several limitations. For example, you cannot possibly rim the or target near completely many times, and also that is not easy to move the working channel to the target point. Is not easy. But the outside-in technique is firstly docking to the working channel to the canvas triangle, and after then choose the target point. Because of that, there is some beginner is not easy, but after you can take a learning curve and expert to this outside-in technique, you can take a more good clinical result with learning the target point more sufficiently. The main target point of the outside-in technique is canvas triangle. After clearing this point, you can see the annulus and the abdominal space more clearly. After that, you can see here the with the outside-in procedures, you can move the working channel like this. Also, the target point also move like this. It means that more easy to the approach to the target point. Only some weak point is the learning curve is some steep compared to the in and out procedures. And you can see the cases of the outside-in cases, like these highly inferior migrated cases and high canal compromised cases and super migrated cases, not easy before inside-out technique, but outside-in technique can possible to remove this all severe cases when the rupture disc is sufficiently. And second debate is the less angled approach or posterolateral approach. Yeah. Yes, if we hope to remove the target point, sometimes we should targeting the more correctly to the target point, because some doctors use the less angled technique, but conventional technique usually use the 25 or 30 degree, but it's very stiff, and sometimes it is not to the target point, but you can see here that this a less angled approach angle and this conventional approach angle. This B view, or you can see the wide canvas triangle, but this less angled approach, you can see here the canvas triangle decreases so much because of that. It says, unfortunately, this less angled approach has some advantage to approach to the target point is more easy, but unfortunately, this less angled approach has some very higher chance of the damage of the exiting nerve root and dural tear, and sometimes visceral nerve damage, visceral organ damage. Because of that, nowadays we can use this conventional outside-in technique is more common in nowadays. And also, we think that maybe first we docking this 30 degree, but it cannot change the target point is not easy. But I already mentioned that if you're using the outside pushers, you can change the angle more easily. And after insert the working channel to the canvas triangle, you can change the angle more target to the pathologic point. And for example, in this case is a high canal compromised case is not easy because of that. If we hope to directly target to here, we need less angled approach. But if we use the outside technique with the mobilization of the working channel, we can render this target point more sufficiently. And I already mentioned that if we're using this mobilized technique of the outside technique, you can approach to the target point near all target point can possible. And third debate issue will be the transforaminal and intraminal. Why we choose the transforaminal? Why we choose the intraminal? There is a third debate. Yeah. Because before the endoscopic spine surgeon believe that transforaminal endoscopic spine is a true minimally invasive approach of the lumbar spinal surgery, because the damage of the neural structure is very, very less. Only some problem is some learning curve and some recurrence is some problem. But and also because of that, some doctors are using the intraminal approach, because the intraminal approach is more familiar to the spine surgeon, and it seems like a more applicable for the beginner. But actually, that is not true. And also, intraminal approach also has some similar to the microscopic open discectomy. Yesterday, I talking that these two cases of the same revision cases, but this case is the after receiving the ligament problem, structural preservation, endoscopy intraminal discectomy, and this open microdiscectomy. After open microdiscectomy, you can see here the severe adhesion. Anyway, this two kind of intraminal still have some different characteristics. This structural preservation is more good for the patient, but unfortunately, this intraminal approach still intraminal endoscopic discectomy still have some problem. If we remove the ligament problem, and after and also resect the annulus and remove the rupture disc. Sometimes after operation, it can make adhesion also and the recurrence also higher chance. Because of that, if it possible, we choose a transforaminal approach if it possible. But maybe L5 version is sometimes difficult because of the L5 version. I'm also doing the internal approach, but another level, all level, doing the transforaminal approach. And fourth debate will be we should preserve the annulus or should not preserve the annulus. There is some fourth debate because previously the transforaminal endoscopic should recommend preserve the annulus, but I know that there's so many problem with the preserve the annulus. There is a first problem is some remaining the remnant disc is a first problem, and the second problem sometimes cannot checking the remnant disc due to the annulus preserve, and also third problem is some remnant recurrent accumulation of into the remnant annulus. Sometimes we can find, because I recommend if it's possible to resect the annulus if we for only some point of the rupture disc point or some pathology point. In my study, I studied many kind of points for recurrence, age, sex degeneration scale, combined HMP, and many kind. Among them, maybe age and degeneration scale, and some disc level, some discitis related to the recurrence, but annulus preservation or not preservation is not related to the recurrence. It means that, for example, in these cases, you can see here the huge protrusion disc and huge rupture disc. But if we not resect here, we cannot remove this huge rupture disc. Only we can remove this point. But firstly, we think that we remove the huge disc and the patient's symptom improved sufficiently. But maybe usually the symptom recur between less than 1 month. Because of that, some doctors believe that there is a recurrence. Actually, there is not recurrence. There is an incomplete surgery. Yes, because of that, and also in some cases the central severe central protrusion disc and huge rupture disc cases, we need some exposure the contralateral side completely. But if we not resect the annulus, it is not possible. Only if we hope to checking the more their complete point, we should remove the annulus. And I already mentioned that there have several kind of disc types, but if we remove all kind of disc, there have many times I saw some remnant disc between the annulus and the vertebral end plate. There has so many remnant disc. Because of that, you should checking the all remnant disc during the transforaminal discectomy. For example, this case is this image seems like this dura, and this I already removed the huge disc here, and you can see this seems like a dura, and this seems like annulus, and the epidermal space maybe seems like a free. But unfortunately, this case you can see here this is a remnant disc in the epidermal space, and I bring the disc to here after cutting the annulus. And maybe here another important debate focus is should after performing the endoscopic discectomy and transforaminal interment, there is an advantage of early return to life. But I always recommend to the patient take absolute bed rest if possible. If possible, the patient more sufficient time. But anyway, I recommend to the patient that minimally you should take a absolute bed rest more than more than 1 week, and that is my recommendation. But usually the patient discharge 2 or 3 days, some patient discharge 1 day later. But anyway, I recommend if you return to your home and your work, you should keep your absolute bed rest more than 1 week. For example, in this case, you can see the ruptured protrusion disc and removed completely, but 3 months later, the disc recurrence rate we can check, because this patient discharged immediately 1 day after operation and returned to his work maybe 2 or 3 days later. And I already mentioned that my study talking that 2 points is very important: age, disc location, and herniated disc level and disc height related to this is the segmental loading component, and this another degenerations can until this agent and combined HMP is the healing component. It means that sufficient healing and less segmental loading is very important to the recovery of the lumbar disc herniation after receiving the endoscopic lumbar discectomy. This 2 point is very important. It means that give a chance of absolute bed rest to the patient. I always recommend this posture to the patient to make a lumbar lordosis. Yes, it's a similar debate. Life quality. Why we doing the endoscopic discectomy for the patient? There is this title is very important. We hope to give a good life quality, not rather than the good return to normal life. Early recovery is not also important, but more important point is not the early ambulation, not only. More important point is more good return to quality of life. That is more important things, because of that. If you follow the patient who received the endoscopic discectomy patient and the microdiscectomy patient, 2 years, 3 years, 4 years, and 5 years, the patient life is completely different, because usually the patient who received the endoscopic discectomy patient sometimes come to me, some complain, I have some pain, maybe I enjoyed my life more than 2 or 3 years completely. This means that the patient returns to normal life. But recently, I have some work and hard work and some exercise. There I have my back pain. It means that the patient again another pain. It means another meaning that the patient already enjoyed his life completely, returned to life completely. And I already mentioned that 2 points recommended to all my followers and doctors: decreasing the recurrence. This 2 point is very important. First point is complete surgery, and second point is absolute bed rest if possible to healing point. That is 2 point is very important. Complete surgery. Should be complete surgery. We talking that already. We thinking that after removing the huge disc in the endoscope view, wow, very big size of disc removed, and the arterial space and the nerve is filtrated completely. Wow, we think that there is complete surgery. Oh no, there is not complete surgery. Sometimes I will show some another interesting case, video cases. Yes, this is my, yesterday I showed these images, and you can see here the endoscopic discectomy cases. These endoscopic discectomy cases have they're excellent and good result, more than 95 of good and excellent result. And recurrence also not so much in my cases. Yes, I will show some of my cases. This, okay. I will show. We saw this case is high canal compromised cases and where rimmed rupture disc. What you can see here, after clearing the canvas triangle, this endoscope or radio frequency? Radio frequency, eloquence or radio frequency. And after that, okay, you can see here this discal space, but this extra space. If we approach it from the in and out, inside out technique, we cannot see this view. But outside in technique, you can see the extra space. And here, rupture disc here. This annulus, this extra space. Nerve root move to more medial side because this huge rupture disc. Now we remove the huge disc. Okay, is sufficient? No, not is sufficient. There are still another huge disc. We still see the free nerve root, but you can see the huge disc removed and it seems like some extra space is free. Is it sufficient? No, we still don't know the free fluctuation of the nerve because of that I cutting the annulus. And during this process, I removed another huge disc in the intradiscal extra space. But you see here another remnant disc here. After then removable, it is sufficient. We already checking the fluctuation here, but no, that is not final. This all located in the extra space, not in intradiscal space. This is final. What? This is a dura and this nerve root here. Yes, because of that, we believe that sometimes we will need a huge disc that is final. But in my experience, maybe many times not final. You should checking the near final, and checking the all free cranial to caudal all free. And I will show some another these highly inferior migrated cases. Okay, in these cases we can exposure this rupture disc point using the drilling and this suprapedicular notch and the drill to here we can expose the extra space. After that, remove the huge disc here. And finally, I will showing the very interesting cases. This intradural ruptured cases. Maybe because you know that the intradural ruptured disc case is very difficult in the first year approach, and also that has a many chance of neural damage and sometimes caudal echina. But if we approach the ventral side, it seems like very comfortable for neural damage, but unfortunately that has some higher chance of nerve root prolapse. Nerve root prolapse have a very serious pain to the patient, but you can see but nowadays many good instruments and materials introduced in the field. In spite of the endoscopic view, we can apply the some dural patch to here. Now you can see here the side of foramen. What? During the shippractical process to expose the epidural space, and you can see here the rupture disc.
You injected the dye into the disc?
Yes, indiocarbon dye here. Then you can remove the rupture disc. But still, what? No, indiocarbon. You can see here the huge hard disk, but this hard disk located in the intradural space. After removing this intradural, you can see the lutret here. Maybe if we not blocking to this point, this prolapse making the severe pain to the patient. Because of that, I patched here. After then, apply the, do you know tacocomb? Tacocomb applied to here.
This thing was PEG-C, right?
Tacos, yes. And after, okay, you can see these images and what? Bleeding? What bleeding? Before it's called that point, you coagulate and control the bleeding using the radio frequency. And 1 week later, the patient walking is comfortable and have no pain. Yes, it's fine. I will show this image in next slide, next lecture, because this is very important. Yes, yesterday I talking. This time is Korean Lunar Happy New Year days, and also nowadays now in Korea have some Winter Olympic season in Pyeongchang. Thank you. Have you any question about this presentation? How many days? But I recommend to the patient, every patient, please take a bed rest in the clinic. Why? Some sitting and lying down posture is completely different from the home, and clinic is completely different because of the clinic. But usually the patient discharge next day. But anyway, I recommend to the patient, okay, if you return to your home, okay, if you hope to return to your work, please keep the absolute bed rest and take your posture, not stooping or some kyphotic posture. That is very dangerous to the recurrence. And recommend you make a natural the lordosis posture. Okay. How long? Maybe. Usually, I recommend to the exercise. Exercise usually starting recommend 1 month later, but you can you can walk less than 30 minutes between 1 month, but your exercise should starting. So more hard exercise you should starting 1 month later.
All the time, we
we understand that patient is lying all the time?
Usually, I recommend to the patient absolute bed rest, but the patient can walk and can rounding and some toilet, anything that all doing. But only some limitation is some not good posture and some exercise and some lifting. There is some limitation.
All right. That is very fascinating to see this, but we are finding difficulty as a beginner in the localization of level and identification of nerve roots. So give us some tips and tricks regarding this.
Sorry, I cannot understand. Please.
We as a beginner, I am finding a difficulty in localizing the level.
Localization of level.
And especially localization of nerve root. So can you give us some tips and tricks?
Localization of level is very important. Yes. Yesterday I talking that preoperatively you should checking the X-ray and MRI same location. It means that we can, if we know the image of the X-ray and some configuration of the vertebral body, you can check the same level at the fluoroscope under the endoscope. And also, you should know that the L4-5 level usually related to the iliac crest. Iliac crest is sometimes higher than L4-5, but usually less than L4-5, or similar to the L4-5 because of that. In the lateral fluoroscope, L4-5 level usually is close to the iliac crest level. But you should checking. More important point is the same configuration of the X-ray and MRI vertebral body.
So let's take a break and please continue with your next presentation.
Next.
We'll take a break and we'll come back for your next presentation then.
Take a rest. Okay.
Days, it depends on the patient. The doctors, they go next day. The common doctor, they go more days. It's like that. We do not have some specific rules. Used to be 7 days, but after the second, they don't let it go. After the
You have to be back in 10 minutes. The live surgery will start then.
ले जाओ 2-3 ले जाओ बस अंदर आग लो
बाकी और कोई चीजें डिस्करेजिंग किया है The coffee break is a
what is this?
Hello? Yeah, we can hear you. Everyone is just taking a 5-minute break and we'll be back. So you guys are preparing. Okay, sir. क्या करना है आगे पीछे आगे पीछे हो गया। इसको दिखा दें ये मेरे पास है इसमें है मेरे पास उसका मुझे व्हाट्सएप करे Basically up to 8 months की हो गए. She came to us when she was 6 months old and left orbital ptosis and कोई है नहीं तो
अच्छा ये cystic था?
Yes, it looks as a component. Biopsy में अभी भी when we made sure from the pathologist उन्हें कहते हैं hematomatous lesion लग रहा है and respiratory epithelium lining है. This is her post-op CT scan. हाँ And we basically just we left the temporal lesion because we couldn't get it. फिर हमने सिर्फ orbital lesion को biopsy and as much as we can take. Pointer?
यहाँ से यहाँ बारोल करें बारोल करके पहले यहाँ बारोल करके आप यहाँ और फिर यहाँ से ऐसे ऐसे आप ऊपर से इस ऑर्बिटल रूफ आती है बस ये वो उसकी प्रॉब्लम से नीचे जाएगी देखिए क्या करते हैं वैसे ही ऑर्बिटल के ऊपर में टिश्यू की समझ वही आती है बाद में कभी वैसे ही फैट होती है इसकी ऑर्बिटल फैट होती है वो भी वैसी रहती है टिश्यू से स्वेलिंग नहीं जाती और बाद में इतनी बड़ी स्वेलिंग होती है आप सिंपल स्टीरॉइड है वो चली जाती है
इसकी विजन अभी भी इंटैक्ट है
ये अच्छी बात है So you are in the third year.
कोई एक तो छोड़ दो मुझे सर वहां से आवाज आ जाएगी तो मैं क्या करूंगी
Early morning. I should here, and then we should have some break for a day. And he didn't arrive. Someone will take him somewhere. Relay. Just to see the signs and such. Otherwise, I wouldn't see this place, the hotel, the Lord stars in the US. I should see something from the camera.
Take this myself. I take this myself. Thank you.
Sunday is a different day in this country.
What's your name?
Freedom.
Some schools have freedom, but hospital have government.
Regular.
Or working in 8 to 2.
So we work 6 days a week.
Yes.
Yeah.
3 days of this.
The holidays, holiday you after late. Oh, I mean holiday, like how many weeks are you off during the year?
Only there activities just after there are no holiday hospitals. How much we can go to the videos.
So it's up to you.
Yes. And they don't know that they don't bother reaching when we want to do all this tomorrow night, good night, next year.
Good. So how many surgeries do you do a year?
Almost 750.
You yourself or?
Yes, no. Only I actually don't have it. Our department is utilized now last year, but still student have to do 2 years as a service. So there are 2 students in line, but we know that we have only general duty doctors, 2 of 2 doctors. And there is no consultant or no assistant. After we did, after 6 years after we had that was in the hospital. That is the final project, right? And then after then I worked in a light hospital, that was 6 years we have seen this one. Then I left the job and then I started this hospital. For the last 16 years, initially that was not, there was no CT scan, but then they gave us CT scan and to be MRI, and now CT and 16 CT. All these
Do everything.
we have this immediate amplifier, we have drill, we have also being in the and we provide this simple easy body system like that. You know, when we started, so 2011 first time neurosurgery started from
the trauma.
Trauma selected trauma, they want selecting trauma. Otherwise, we have 30 to 35, 35 to 40 years.
अफसर की आवाज कम आ रही है हाँ? No. Thank you. You have your camera? You have camera?
The big surgery is like this, or this angiomas, and everything. It's more in private or in the.
No, it's for the product is still or the people in your work. I have my own setup, like very small one. I'm not sure. So we are.
Can you see them? No, I saw them. It was working fine. Sir,
We are very good.
connected. Everything's connected. Also,
We operate 8 to 10 per year. Because people usually they are when the patient is not suffering and he's sick, they are ready. When he's recovered, this is no, the patient is okay. No, we don't want to. Yes, most of the time they don't want to get healthy. And for example, there is tumor. If tumor is benign, tumor, they are ready to get healthy. For example, if there is glioma, to tell them that it is cancer recurrence according to the they say if it is going to develop after 6 months, what is the benefit to it?
it's connected to the radio.
Assalamu alaikum. Can you hear us? Hello. Assalamu alaikum.
Can you hear us? Yes, sir.
Yes, good morning. How are you doing?
Fine, fine. Just waiting.
We are finishing the preparation of
Yes.
of the surgical field. You have probably seen the I don't know if you have the possibility to see the CT scan and the MRI.
No, we have seen first.
I don't know if you have seen this.
I've seen it.
Okay, it is a very, very strange and unusual case of, there is certainly some malformation because of the, as you see, the left ear is has a quite severe malformation, and there is a very significant bone malformation with one would expect some kind of scalloping in presence of a cystic expansive process like this, and instead the bone is thickened, and there are bone spicula. There are bone spicula inside the inside the cystic malformation.
He's describing.
Yes. This low like this. Nice. Thank you. Thanks. Okay. Yes. Thank you. Yes, why not? Yes. And one of there is a significant part that is that goes below the temporal fossa, that goes down into the infratemporal area, and the communication with the orbit is not very clear. It looks as if it is done through a very, very enlarged optic canal, but it is very difficult because the CT scan cuts are not very, very thin, and it's very difficult to follow on the CT scan the optic nerve. So it is quite difficult to understand the anatomy when there is such a significant malformation. So it's something we have to invent a little bit. I have never seen a malformation like this, but we have to adapt our surgery to a lesion that is very anterior in the temporal area. So it's the temporal pole and the infratemporal fossa. So we have to go very, very down into the temporal along the tragus. And at the same time, we have to ensure with our incision the possibility to expose the orbital roof and to expose completely the periorbital. It could be possible and necessary to remove the orbital bar. If do we have a oscillating saw?
Can we get an oscillating saw?
No. Her vision is present. It's a 6-month-old baby. She had a left orbital proptosis since birth. Her vision and everything else was normal. This was her post-op picture right now. That's how she looks like.
Very nice.
This is her pre-op MRI, axial image. This has a temporal lesion and the orbital region. This is a pre-op. Yeah, she was operated in December. Again, because we left the temporal lesion behind, because it was up.
Can you raise the table a little bit?
Table up.
This is her post-op CT scan.
It's okay, thank you. Is that okay for you?
Yes,
okay. Is that okay for you?
Yes.
The height of the table?
Yes, yes.
Okay. Okay, this is the mono. Okay. Bipolar, and is it connected?
Yes,
So can you please remove my glasses? Okay, thanks.
Pre-op, Sorry. Wait.
No, I don't think we are going to infiltrate. Do you infiltrate always with this? This is saline. This is saline or adrenaline?
Adrenaline.
Adrenaline.
9.
Do you infiltrate under the scalp? No.
At the incision site.
Okay, only the incision.
Yes.
Only incision.
But sir, it's a scar.
Yeah, it's a scar. Yeah. Okay. Tell us when we can start. Can we start?
Yes. Sir, can we start?
Okay, please. Okay. You want to start the skin incision?
Okay.
Sir, as you wish, sir.
Okay, please. Yes. Okay, I do. Okay. Thank you. Okay. So we start the skin incision from below. Okay. No, not now, not now. Thank you.
और ये पेटियां देते वाइड ले ना लंबा कौन सा ले लो मैंने पता मैंने ले लो
Bipolar?
Yeah, please, bipolar. First ले एक को first ले pedal
Is it a little bit too strong? The skin? This-
first ले लीजिए please ये एक मुझे देना one more
Okay. Bipolar?
bipolar please section कर ले section please आगे section कर लो
Okay, thank you. Yes? Okay.
Can you guys focus on the incision? We can't see.
Can you focus on the incision, please?
Sure. Focus on the incision.
Irrigation
Still can't see. We only see hands.
काम नहीं करना just one minute it's out of order bipolar is out of order बंद करो ये bipolar सही कर दो please बंद कर दो अंदर दिया हो गई काम नहीं कर रही monopolar भी sir just one minute machine is
Monopolar is not on. It's the usual starting. It's always like that. Don't worry. No, it's not working.
yes sir काम नहीं कर रही यार
Maybe the bipolar is working.